Good evening, everyone. Welcome to the third session on in this series, a CRD education series. And today's focus is on pollen, aspergillus, mold, and the components related to that. I would like to call upon Dr. Neeraj Gupta so that he can just give an overview of what exactly we are doing this. So Dr. Neeraj Gupta is IP President for Allergy Chapter, and he is the Senior Pediatrician, Pediatric Consultant at Gangaram Hospital. Over to you, Dr. Neeraj.
Thank you, Alka. Thank you very much. So, friends, as we understand that now we are moving to the third episode of this CRD education series. And this is something like a very wonderful initiative which has been taken by IAP Allergy Chapter in collaboration with Thermo Fisher Scientific, and in which we have already discussed about the important components of peanut and dust mite. Today is very important day in which we will be discussing another important allergen, which is pollen as well as aspergillus, with the learned faculties with us. And I wish all of you the best to attend this webinar. Thank you very much. Back to Alka.
Thank you so much, sir. I would just like to inform all the participants here that this session is being recorded. This webinar is being recorded. And by continuing to be in this webinar, you're consenting to be photographed, videotaped, live streamed, or otherwise being recorded. So by speaking or by writing anything, you are expressing your consent, your views to be shared with the public at large. And if you understand that if you don't want to be get recorded, you must avoid speaking or expressing your views. Okay. And we also understand that since you have granted your consent, we are going to use these recordings wherever possible, and we'll be distributing it at various media platforms that we'll be using. For today's session, our speaker for today is Dr. Vikram Patra. So I would like to introduce Dr. Vikram Patra. He is a consultant pediatric allergy affiliated to Apollo Hospital and MGM, New Bombay Hospital, Navi Mumbai. He is ex-associate professor, MGM Medical Institute of Health Sciences, Navi Mumbai. He is a visiting faculty at Savita University for the course of fellowship in allergy and clinical immunology, and he is executive board member, West Zone for IP Allergy and Applied Immunology chapter. He is the treasurer, Maharashtra State chapter of IP Allergy chapter. And Dr. Patra is core member and faculty for IP PAAAC, Pediatric Allergy Asthma course. He has been a contributor and national trainer for various IP allergy modules, given rational evaluation of allergies in pediatric practice, childhood allergic diseases, education, demystifying allergic disorders, trainer for IP, United Airways under 5 visas and tough modules. And he has many publications under his name. He has authored for chapter food allergy in IP standard treatment guidelines. He has authored for chapter anaphylaxis in IP case-based reviews in pediatric allergies. He has authored for biologicals and silk allergy in comprehensive textbook of allergy, and he has authored for chapters biologicals and food allergy lecture notes in allergy. His areas of interest are urticaria, anaphylaxis, and immunotherapy. So over to you, Dr. Patra. I'll stop sharing my screen. Please share your presentation, and you can start with the session, sir.
So thank you, Alka, for the kind introduction. Good evening, everyone. At the outset, let me thanks our IP allergy chapter for giving me the opportunity, and I extend my thanks to Thermo Fisher. So I will be sharing, and is my slide visible?
Yes, sir. Yes, sir.
Fine. So I am actually highly obliged and lucky to get this topic, which is very difficult. And not only difficult, it is a growing thing, an evolving thing in the field of allergy. So let me start with a report. Now, many of us, we are getting these reports of component resolved diagnosis, right? So when these reports comes like this, with so many things being detectable as sensitization, we many times are confused. It's difficult to interpret. So same is true for all the allergens, and when it comes to pollens, it becomes more difficult. So it will be unfair if I start directly with the component result diagnosis. Let me go through the basics of pollen allergy first. What is pollen allergy? It's known as hay fever, used to be called as, now we know it as seasonal allergic rhinitis, which occurs due to Ig immune response to airborne pollens. Major pollen sources are basically trees, grasses, and weeds. So, coming to the prevalence of pollen allergies are increasing globally, as we know. Pollen allergies affect approximately 10 to 20% of the global population, and prevalence varies by region and environment depending on the vegetation over there. Rising incidence attributed to climate change and extended pollen seasons, and to the environmental pollutions also. So when I mentioned about the regional variation, in our India also we have different regions, and according to the different regions we have different pollens which are widely found. So in the northern area, if I consider the Himalayan belts, there we get birch and alder, which is similar to the what we get in European countries and temperate zone. And in the subtropical and tropical areas like northern India, we get Prosopis, Zulifera, Ricinus communis. In the central and eastern India, we get common allergens like grasses, parthenium, and Cocos nucifera. In the southern India, we have Artemisia and Eucalyptus as a common allergens. So why we need to know this? Because so whenever we are practicing as an allergist, we need to know what are the name, or what are the native pollens or trees or weeds or grasses around our area, because we are going to get our patients over there. There is no point in checking the pollens which are not available in our area. So we have to have a geographical knowledge about the pollens in our area. So there are various pollen calendars also, because not only the geographical variation, we have seasonal variation also. Seasonal variation in say it depends on the flowering seasons. So we can see the trees, grasses, and weeds, they flower at different times. But many a times, to make the scene complicated or complex, many flowering seasons they coincide with each other. From this image, we can see. This is a study from our India itself. Depending on the season, from Feb to April, spring season, autumn, and winter, what pollens are prevalent. We can see grasses generally cynodon dactylon, they are all throughout the year, but the flowering season will be more in the from the month of November till April. So similarly, different it's a huge list. We have to keep in our table as a ready reckoner whenever we deal with any patients with. So there are different pollen calendars area wise. So this is a example of pollen calendar of Maharashtra. Different pollens are mentioned and the pollination season is mentioned. Now, clinical manifestation, as in other pollen allergy symptoms, pollen allergy symptoms, they include more of sneezing. Like last time dust mite was discussed, in the dust mites, nasal symptoms, they are more of blockage symptoms. But in pollen allergy, sneezing is more, headaches, itchy eye. Rhinoconjunctivitis is very typical in pollen allergies. Nasal congestion, nasal irritations, affecting the sleep, leading to daytime poor concentration, daytime fatigability, and sometimes coughing also. So current diagnostic approach, how do we diagnose? And traditionally, we have been diagnosing by skin prick test, because we know this is considered to be the gold standard. It is quick, cheap, but can't differentiate between cross reactivity. I'm sure all of us must have experienced when we go for pollen skin prick test, we get many a times polysensitization. So we are stuck over there whether these are just real sensitization or just because of the cross reactivity, they are all positive. Then we have serum specific Ig testing. They identify allergen specific Ig levels. Then total Ig, we know they are non-specific and they're influenced by many factors. We in all our platforms we say the very limited role is there, so it should not be sent routinely. So what are the limitations of traditional testing? As we discussed, cross reactivity and false positive. So even if there is cross reactivity, the skin prick test or the serum Ig, in these conditions, what we are using the crude extract, and against the crude extract, we are demonstrating the IgE. So allergen extracts contain multiple proteins, leading to possible false positivities. They cannot differentiate between genuine sensitization and cross reactivity. And most importantly, all these available allergens, they lack standardization in extract composition. And because of this, risk of over treatment is many a time seen when we get polysensitization patients. So, as I mentioned, we are taking the crude extracts. So, better we should learn about what is the structure of allergen in short. Allergens basically they can be monomers or dimers, and all these allergens they have antigenic determinants. They are called as epitopes, which are recognized by the IgE. So a source may contain several allergens. So if I take a allergen molecule, they can have several allergens in it. And each one may possess a number of potential epitopes, that is areas of a protein that interact with the B and T cell receptors on lymphocytes, and thus producing individual specific Ig for each epitope. So thus Ig in a patient serum is polyclonal. So if we measure serum specific Ig against say one pollen, it's actually polyclonal. That is mixed of specific IGs against the various components. And it will reflect that produced to different allergens as well as to different parts of an individual allergens. Now, basic principle of molecular allergology. So already in the first two lectures, this was discussed in a short. Now, allergen source can be a pollen, a peanut, or an apple. So they contain, this is the crude extract. So in crude extract, we can see many molecules are there, many epitopes are there. So the specific, we can see certain specific things are there. So in the pollen, this brown color is the specific allergen component, and this blue color, these blue colors which are present in these allergen extracts, they are cross-reactive. They are present in all. They are ubiquitous. So they are called as pan-allergen. So component result diagnosis, it uses purified native or recombinant allergens to detect Ig to specific components. So whatever components which are specific to the given allergen or the molecule, we allergen source, CRD detects those. The common platforms include our Immunocap, ISAC, LX2, Uroline, etc. So they can be singleplex and multiplex. So they allows precise identification of sensitizing proteins, and thus it differentiates between true allergy and cross sensitization. It leads to a better risk stratification and personalized treatment. So platforms, as I discussed, this can be singleplex or the multiplex. So this is the Yaki guideline on the diagnostic approach using the singleplex. So first of all, history. We have to correlate everything with the history first. Detailed history is important. And then the next step is the extract-based sensitization test with interpretation. So what are those? Those are what we do: skin prick test and the serum-specific IgE test or the basophil activation test with the extracts. The next step, once we get the positive result, we have to confirm by the molecular based IgE testing. That is the second level IgE testing for the selected molecules. And those selected molecules which are specific, they are called as genuine signature or the molecular markers. So if we get those, then we are sure the diagnosis is confirmed and we can go ahead with the therapeutic challenge, and later on we can go for the therapeutic approach by giving allergen immunotherapy, and allergen avoidance can be advised. So what is the difference basically? As I mentioned, it offers improved precision, reproducibility is more because they are standardized, and predictive value is more. The extracts, the crude extracts, they are heterogeneous mixtures, so the specificity is less. And when it comes to molecular, the specificity goes high because we are taking the single purified proteins. So thus we can detect primary sensitizers versus cross-reactive pan-allergens. So coming to the clinical use of CRD, so it differentiates between genuine sensitizers versus cross-reactivity. So high Ig to major allergens, it tells us about the true sensitization. And if some pan allergens like profilin, PR10, then NSLTP, all these are there, then it suggests more of cross reactivity. Then depending on the component sensitization patterns, monosensitization usually indicates single source allergy. The diagnosis is very clear. But when it comes to polysensitization, multiple genuine sources or pan allergen sensitizations are also involved. So that's why it is important to predict the disease persistence and severity. So when it comes to quantitative interpretation, higher levels of Ig correlate with stronger sensitization in most of the cases, not in everything. Then it helps prioritize allergens in immunotherapy. So if we are getting a clear cut the molecule marker or the signature molecule, then we can directly go ahead with immunotherapy. But the thresholds vary by component and patient's context. It helps in clinical decision making. It identifies patients who would benefit from AIT. So there are various components. If some components are present, the patient may not likely to respond to AIT, as it must have been discussed in the. It was discussed in the dust mite talk also. The presence of certain components will not. Those patients will not respond to AIT. So thus and then there are various components which can cause to minor reactions. So it can, by knowing that, we can avoid unnecessary food elimination. Personalized avoidance measures can be advised rather than giving a bucket list. Then assess seeing the risk for systemic versus local reactions. Certain component, if they are sensitized to certain components, they will end up with severe reactions like anaphylaxis. But if they are sensitized to some minor allergens or minor components, they will present to with minor symptoms like oral allergy symptoms. So before going to the component result diagnosis, the molecules, a quick revision for the allergen nomenclature. It is established by the International Union of Immunologic Societies. The first three letters, it tells about the genus, and the first letter is the species. And then the Arabic numeral is given, reflecting either the order in which the allergen was isolated or its clinical importance or both. For example, this cat antigen, Felix domesticus is the scientific name. So initial three letters of the genus, the initial one letter of the um, species, and the order of isolation, the numerical is given. For similarly for HD mite, DP, the P1, the P2, for Ambrosia trifida, MT5, MA1, for Artemisia, ART, V1. So all these are given. So I was talking about the major allergens and the minor allergens. So what are these basically? So what is major allergen? Major allergen means what? Allergens are present everything. So it generally, if we take a pool of patients, those who are sensitized to the allergen. So major allergen components, they sensitizes more than 80% of a predisposed and exposed population. A significant proportion of total specific serum IgE is directed to the allergen, and removal of the allergen from the source material greatly reduces the biological and the immunochemical activity of the extract. The allergen, major allergen represents a significant proportion of the total extracellular protein in the extract. So the allergen may be used as a marker of environmental exposure. Both humoral IgE and the cellular T cell basophil responses to the allergen can be measured in high proportion of a sensitized population for these major allergens. What are pan allergens? These are basically cross-reactive allergens. So among phylogenetically related species, different HDMs, different pollens, these pan allergens, they cross-reactivity among these phylogenetically even dissimilar species also. So HDMs, there will be cross-reactivity between the Dermatophytes farinae, Pteronosinus, but they will have cross reactions with the dissimilar species, like we know about the tropomycin. Similar too is for profilins. Profilins, when I talk about the pollens, profilins, they cross react with dissimilar species like pollens and fruits. They will have similarity between the grasses as well as the fruits. So respiratory sensitization can give rise to oral allergy syndrome for these pan allergens in patient eating food containing these allergens. So the different pollen allergen protein groups, when we talked about these major and minor allergens or pan allergens, so they are all grouped into a few protein groups. So they are classified as cell wall modified allergens. Most are major allergens and include the beta expansins, as seen in the grass pollens, and the pectin degrading allergens like pectin methyl esterase, pectin lysis, as seen in the weed pollens. Then we have allergens which are involved in the defense mechanism. Even the plants, they have their immune system. So these pathogenesis related proteins, PR, families have been identified. They are responsible for defense purpose. So various tree pollens, they are associated with the PR2, 5, 10, which is the PR10 is the common one. And even they are found in the weeds also. But none of the grass pollen allergens are members of PR. So what is PR basically? So the major birch pollen allergen, that is the BET V1, represents the archetype of all PR10 like allergen. And this is considered to be the primary sensitizers in birch pollen endemic region. Suppose a person is staying in the Himalayan belt, and if they come with the birch pollen sensitization on skin prick test, and if we go for the component, then BET V1 will be present approximately 80 to 100% time, 100% of the cases. So PR10 proteins, they defend plants against fungi and other microorganisms. Their homologs are also present in a large number of plant-derived foods. So that's why a minute amounts of PR10 like allergens are present in raw fruits, nuts, vegetables, and legumes. And these are responsible for oral allergy syndrome or sometimes severe reactions. So PR10 like allergens, we can see from this, the birch, they can cross reacts with so many fruit items. We can see apple, peach, pear, strawberry, kiwi, celery, hazelnut, walnut, peanut. So all these, they can cross react. So these are the different PR10 like allergens. The archetype is the BET V1, but you can see in the apple Maldive one, it is also a PR10. In the peach, it is the Pru P1. In soybean, it is Glyam4. In peanut, it is the RH8. Suppose a person who's staying in the Himalayan belt comes to us with the history of tingling sensation around the mouth after eating peanut. So what we realize? So this is basically the primary sensitizer is not the peanut. The primary sensitizer is the birch pollen, and it is the cross reactivity which leads to oral allergy syndrome with the peanut. So there are other protein groups like non-specific lipid transfer proteins. These are minor allergens in pollens, but also they are present in seeds, latex, fruits, and vegetables. But it is the major allergen in mugwort pollen, Artemisia. Then we have profilins and polcalcins. These are minor pan-allergens involved in oral allergy syndrome or food cross-activity syndrome. So coming to the non-specific lipid transfer protein, this is again a complex thing which is coming up in a big way. Most frequent type of food allergy in adults and adolescents in southern European countries, and even we are getting LTP syndrome cases. Severity of the reactions seems to be higher in monosensitized LTP patients and milder when patients are also sensitized to profilin. Interestingly, now, when only monosensitization to LTP is there, the severity of the reactions will be more. Peach Pru P3, the major allergen, this is a precursor role in sensitization to other LTP. So like birch, they are the primary sensitizers. For LTP, peach is considered to be the primary sensitizing allergen. And the component which is responsible for this is the Pru P3, where we saw Pru P1 is the PR10. So the level of specific IgE to Pru P3 does not correlate with the severity of reaction. So this is one of the exception. So in the LTP, the level of in other pollens and other allergens we saw the clinical severity is more with the more the level of this serum specific IgE is there. But in case of LTP, it is not true. And most of the reactions to LTPs, they are frequently associated with different cofactors such as NSAIDs, intake, or even exercise induced. So these are the LTP examples, the allergen components. In the peach, the progenitor or the archetype, Pru P3. In apple, MALD3, their structure is similar, so the same number. Then in the peanut, RH9. So this is one of the major allergens in the peanut, which can lead to, it's a heat stable allergen, which can lead to anaphylaxis. Then in wheat, try A14. In the grape, wheat V1, tomato, Sola 16. Then in the mugwort RTV3, it is a major allergen, which is LTP, which is found in Artemisia. Then olive, Ole E7 and others. Coming to polcalcins, these are the minor allergens. These are calcium binding proteins. There is an extensive cross reactivity of Ig between pollen and polcalcin. And the most representative pollen, polcalcin, is the sorry, PHL-P7, that is from the Timothy grass. So if PHL-P7 is found in our multiplex report, then the chances of having polysensitization will be more, and the polysensitization will be more will be seen with weeds, trees, as well as grass. So if you come across a picture where the patient is sensitized to weeds, trees, and grasses, always look for the polcalcin, the PHL-P7, and that must be positive. The corresponding homologous for the PHL-P7 is the BATV4 in the birch, and for the elder it is ALNG4. So algorithm approach for this polcalcin. So when you get this kind of polysensitization to pollens, the skin prick test will come positive to tree pollens, grass pollens, as well as to weed pollens. The next step, what we should do, we should check for the serum specific Ig to allergens. The serum specific Ig to allergen components. And if we get the primary sensitizers like VET-B1, OLE-E1 for the olive, PHLP1 for the Timothy grass, Artemisian, the ARTV1 for the Artemisia, then we are sure these are the primary sensitizers. But if we get pan-allergens like prophylins, polcalcins, and LTBT, so we are now sure that this is not co-sensitization. This polysensitization is because of the cross-sensitization. So positive to allergen specific to primary sensitization. So if these are positive, we'll consider allergen immunotherapy to the relevant pollens. But if positive to the pan allergens, we have to explain polysensitization to pollen and explain more intense and longer duration of sensitization to S. So here AIT will not help. Coming to prophylins. So prophylins are basically, they are the most common pan allergens present in the pollen allergic patients. So as a minor pollen allergen, sensitization is almost always associated with sensitization to major pollen allergen. So it is unlikely that the patient will come to you with the positive report for prophylin component and major are not there. So generally major will also be there, and along with that minor will be there. So there is a good concept of molecular spreading. So at the beginning, basically at the beginning of in the early childhood, when the patient is getting sensitization, even the preclinical stage, patient will get sensitized to these genuine markers or the signature molecules, the main specific allergens. But as the age progresses, as the exposure progresses, the sensitization to other components also increase. So if we are checking a patient at the later age, patient will come to us for immunotherapy at a later age when the symptoms are florid, not getting controlled with pharmacotherapy. Then we look at, and when we go for this component result diagnosis, we see many components being positive. But if there is strong family history, and there is a concept called as early immunotherapy, where at the beginning of the symptoms or beginning of the clinical features, we can start immunotherapy. And studies are going on where we can start allergen immunotherapy to prevent further clinical course in the preclinical stage in the childhood. So up to 50% of sensitized patients may have food allergy, oral allergy syndrome in most cases. So a child may present to us with pollen allergy in the first, say 5 to 10 years of age with typical respiratory symptoms, but later on in the adolescent age group, they come with even oral allergy syndrome because of the sensitization to these pan allergens. Clinical reactivity to raw tomato, melon, watermelon, banana, and citrus fruits is typically associated with prophylline hypersensitivity. So if a patient comes to us and says about allergy to these vegetables or fresh pulpy fruits, then always we should think that underlying some pollen allergy is going on, and this is the cross reactivity because of the prophylines. Latex and prophylins, this is again an interesting thing. Now a patient can come when there is polysensitization to pollens. So when we do for latex also, the latex may come positive on the skin prick test as well as for the serum specific IgE for the crude extract of latex. And these natural rubber latex, they also contain profilin, which is the HEVB8 component. And patients sensitized uniquely to profilin can undergo surgery without any risk as latex gloves. So when SPT, when we do SPT and latex compositive, we may directly ask the patient to avoid latex, to avoid surgery. So the cost of surgery may increase to have latex-free surgical equipments. So if we go for component for latex, and if other this major HEV B1, B3, they are negative, but only HEV B8 is positive, then we need not restrict them for surgery, because these instruments, they lack this profilin, because they are all processed and profilin is highly heat labile, so they get destroyed. So coming to the specific allergens like tree allergens, the trees most commonly causing allergy belongs to the orders Phagels, Lemmiels, Pinnels, and Proteoles. So Phagels are basically the birch, the Betulaceae, and the Fagaceae. These are the two groups belonging to the order of Phagellus. These are the two families. So in this, the birch, the Betula, is the leading one, followed by alder and followed by hazelnut. And for among the Lemmiels, Oleaceae, the Olea, the this thing is positive. Then from the Pinnels order, Cypress is the cedar trees, which are again found in the Himalayan belt, and the Proteals, the plane tree. So these are the tree pollen allergens we can see from this thing. The major four, the Betulaceae, the Platanaceae, Oleaceae, and the Cupraceae from these different groups. So this is the Phagels. So here we can see there are different components in the Betulaceae group. So here the green one is the molecular marker or the signature molecule, and the others are cross-reactive. And so when it comes to tree Betulaceae allergens, the PR10 is the major allergen. So this is BET-V1, like are the major allergens, and Fagel pollen often associated with an oral allergy syndrome, as we discussed earlier. Then in the Cupraceae, CUPA1 reactivity is the specific marker for the sensitization to the Cupraceae family, the cedar family, and even the Cup S2 also. From the Oleaceae, olive pollen allergy is caused by Ole E1 sensitization in about 70% of cases. Ole E1 is fully cross-reactive to Fre E1. So they are the same order or the same family. Then from the Plantanaceae, Pla A1 and Pla A2 may serve as a marker for primary sensitization to plane tree pollen. The plane tree is the typical the London plane tree. So whether we have this birch pollen in our country, yes, in the Himalayan belt we get these kind of trees. That is the Betula utilis species is there. In local language we call it as Bhoj Patra, because the bark is of use. So these barks were used in our Vedic period also. All these Vedas were written on this Bhoj Patra. So that is these are, and our all our Rishi Muni used to be there in the Himalayan belt. So these Betula species are there in our country also. This Cupraceae, we all know when we go to Himalayan area, we see these kind of trees. The cedar trees, the pine trees, they belong to Cupraceae. And we know we see this kind of cones fallen on the roadside. So these are typical belongs to the Cupraceae pinnels family. Butalaceae, as we discussed, the BET-V1, the PR10 BET-V family member, they are similar. The elder also, the ALNG1, and from the hazelnut, core A1. So all these are similar homologous molecules, that is PR10. They are also called as BET-V1 family member. And you can see this is 95%. As I mentioned, for the to call it as to be the major allergen, it has to be present in the more than 80% of the sensitized patient. So you can see here. So Hazel, 100% patient will have core A1 positive. And in elder also, 100% of the elder sensitized patient will have ALNG1 molecule sensitization. But when it come to tropical countries, we have more of this Fables group, the Fabaceae family, that is the Prosopis julifera, mesquites, and the acacia. The acacia is the bubble tree, what we call it as bubble tree. So they are very common in our country, and they have ole E1 like protein family member. So that's why, and now olive was not native to our country, but in widely now in Gujarat and Rajasthan, olive plantations are there. It is being cultivated for commercial use, and we are getting even ole E1 positive in many compound result diagnosis reports. So this ole E1 is the common olive group. It's a separate group which is again present in our Acacia and the Prosopis mescates also. The Pro J1, ACAF1, and the ole E1, they are all homologous. This is the London plant tree, which is uncommon in our country. But what is typical about this is the plant tree Pla A3 belongs to the family of NSLTP and showing 58.3 sequence identity with the NSLTP of the peach, that is the PRU-P3. So diagnostic algorithms for suspected tree pollen allergy, if it is monoreactive, if, after taking history, we go for the skin prick test for the tree pollens. And in this skin prick test, if we get monoreactivity, we have to confirm with the serum specific IgE. Diagnosis is confirmed after specific IgE evaluation. We can directly start with the tree pollen AIT. There is no confusion at all. But if there is polyreactivity to all extracts on skin prick test, then we have to go for the components. And if genuine sensitization to all tree pollens, then we have to go for the history. We have to revisit the history, the pollination, the symptom correlating with the pollination, and then we have to go for specific tree pollen AIT for culprit allergen. But in the polyreactive patients, if these pan allergens comes positive like BETV2, BETV4, then no AIT is suggested in such cases. Given an example, polyreactivity to plane tree and olive tree if it was done, and only E1, player 1, these are the genuine signature molecules, then we have to go for AIT. But if the LTP molecules like PLA A3, OLE E7 are there, then AIT is not recommended. So coming to major grass pollen allergens now, the Timothy grass, we have this Timothy grass, we have Kentucky grass, we have in our country more of Bermuda grass, the Cynodon dactyl. So this Timothy grass is present more in the temperate climate or the temperate region, whereas in our subtropical, tropical areas, we have more of Bermuda grass, Cyn D1. So Cyn D1 is a major allergen for Bermuda grass. And for the Timothy grass, the PHLP1 is often the initiator molecule in grass pollen allergy, marker for true grass pollen allergy. Whereas PHLP2 as well as PHLP5, they are also sensitive. After PHLP1, the major allergen or the signature molecules are P2 and P5 also. But that PHLP7, as I mentioned, it's a polcalcin, which is, if it comes positive, then the chances of having polyreactivity to weeds, trees, and grasses are more. Then profilin PHLP12. So one more thing we need to understand, if PHLP7 is more, then the chances of severe reactions are more, and they can show side effects or the reaction to immunotherapy to the Timothy grass or the grass pollen. So this is the diagnostic algorithms for suspected grass pollen allergy. So if from the clinical history we get grass pollen allergy history suggests your grass pollen allergy, then SPT to the individual grasses or the grass mix can be done. If it is negative, then no AIT is required. But if it comes positive, then we send the, this is not for our country basically, the PHLP1 we send. And if that comes positive, we go for pollen AIT. And along with PHLP1, if PHLP7 and PHLP12 comes positive, that it suggests that the molecular spreading has taken place. And this is also the broad pollen cross reactivity. The asthma risk is more when PHL, as I mentioned, the severe reactions are there. And if PHLP12 is there, along with the respiratory, we can have oral allergy syndromes. But if PHLP1 is negative, so then the next step, what we do is, as I mentioned, after PHLP1, P2 and P5, they are also major allergens or the true allergens. If they come positive, still we will go for the immunotherapy. Coming to weed pollen allergens, common weeds like ragweed, mugwort, Russian thistle, and English plantain are important allergen sources, typically flowering in summer through the autumn. The biogeographical range and pollination periods of allergenic weeds can overlap, confounding accurate allergy diagnosis. So their different weeds can overlap. And the habitat and flowering period of many weeds, they coincide with even the grass pollens too. So making it more difficult. So how to diagnose then? So if IG to weeds should be consequently tested if symptom persists for some weeks, because first thing will come to our mind will be grass pollen, which is more common than the weed allergy. So if the symptom persists even after the pollination season of grass has gone, then we should check for the weeds. So these are the typical different weeds which are present. And when we do skin prick test, so they are the groups. So we need not do everything. So ambrosia, then artemisia, parthenium, helenthus, that's the sunflower. They belong to Asteraceae group. Then we have Amaranthaceae group where we have Xenopodium album, the Salsola cali, what is called as Russian thistle, and the Amaranthus species. Then we have Urticaceae, Plantageneaceae, and the other annual mercury plants. So these are all the weeds which are present. So the common allergen components what we get for ambrosia are the AMB-A1 and AMB-A4, where AMB-A1 is a useful marker for weed sensitization. But this cross reacts with Artemisia V6 from mugwort and Hell A6 from sunflower. So if a patient comes to us with a skin prick test positive for both ambrosia as well as artemisia, and if you go for the skin prick test and component test, and if you get MA1 and you get RTV-V6, but you are not RTV1 is negative, then you will go for immunotherapy for ambrosia, because the primary sensitizer here is ambrosia species, whereas that RTV6 came positive because of the cross reactivity, the MA1. Similarly, for artemisia, we have mugwort. Artemisia, we have RTV1 and RTV3 and RTV6 also, as discussed. So RTV1 is the marker, is the primary sensitizer or the initiator molecule. So, but it also cross reacts with ragweed MA4. So if MA1 is negative, MA4 is positive, RV1 is positive, then the AID will be given for the artemisia. So this is the use of the CRD, where we can have a therapeutic guidance from the appropriate therapy can be done. And this RTV3, it is a LTP. So it is seen, even it may come positive in LTP syndrome patients. So these are the different protein groups which are present in weeds: the pectate lyase MA1, the RTV6, and the sunflower LA6. These are all pectate lyases. The plant defensin like proteins: the RTV1, the MA4, and the feverfew, the Parthenium H1. So a patient who is sensitized to artemisia, even they will show sensitization or positivity on the skin prick test for the Parthenium. Then lipid transfer proteins responsible for cross-reactivity, food syndrome, even anaphylaxis also on consuming fruit items. The ATV3 from mugwort, it cross-reacts with the CRUP3 peach fruit, the initiator molecule for the LTP. And MA6 also is the lipid transfer proteins. Then we have typical that OLE1 like proteins, which we saw in the tree pollens. Then we have olive E1, then Russian thistle, all these weeds, they cross react with the OLE1 like proteins. So in many reports of CRD in our country, we get Russian thistle to be positive. But Russian thistles are not available in our country. They are basically grown in the desert areas. So if a patient has not been exposed to any desert areas and still if this thing come positive, and that is because of the OLE1 category cross reactivity. So this is the diagnostic algorithms for suspected weed pollen allergy, ragweed and mugwort. Now case history, pollen, because both the pollination season is same, the ambrosia as well as the artemisia, both will have present with rhinoconjugal symptoms and the asthma symptoms during the late summer to autumn period. The skin prick test using ragweed and mugwort pollen extract we should go for. If serum specific IG for ragweed or the skin prick test for ragweed comes positive and mugwort is negative, then we know this is the primary ragweed pollen allergy. But if mugwort is positive and ragweed is negative, this is primary mugwort allergy. But if both are positive, then the role of component comes positive. So you have to look for the initiator molecule which is present. If MA1 is present and rest other things are negative, then again, though the skin prick test showed positivity to both, but it is primary ragweed pollen allergy. But if RTV1 V6 is present and A1 is absent, then it is primary mugwort pollen allergy. But if MA1, RTV1 both are there, then this is called as co-sensitization. Then we have to consider AIT for both. So here I finish my pollen this thing. So in short, we'll discuss about the fungal allergens, how the component result diagnosis can help in fungal allergens. Now for fungi, these are molds are ubiquitous, but the sensitization rate to mold spores in the general population is relatively low. Though the exposure is more, but the prevalence or the sensitization pattern is relatively low as compared to the dust mites and pollens. Mold sensitization is more common in asthmatics and should be considered in the diagnosis. So if we are getting a patient of asthmatics, we must test for mold. So of the huge variety of molds worldwide, only few species can be used in allergy testing. But the most difficult part is that mold extracts, they are very difficult to produce, and standardization of mold allergen extracts is very poor even with the international allergens. So here, that's why for improving the mold allergy diagnosis, we have to use these allergen components. So fungi, they are basically spores, but other parts are also allergenic. The majority of fungal allergens are proteins or glycoproteins. As I mentioned, sensitization may occur with exposure to fragmented spores or even the hyphae also. And fungi of clinical importance includes our Aspergillus, Penicillium, Cladosporium, and Alternaria species. So only standardized fungi which is standardized is the Alternaria, and immunotherapy is available for only Alternaria. Aspergillus fumigatus. Now, when it comes to asthma, Aspergillus fumigatus, the Aspergillus fumigatus can present to us with two types of things. One is Aspergillus sensitized asthma. That means asthma patients, when you do for skin prick test, you may get type 1 type of allergy to Aspergillus fumigatus. But many a times in asthmatic patient, uncontrolled asthma patients, there can be have the type 3 allergy because of this Aspergillus fumigatus, and that is what we call it as allergic bronchopulmonary aspergillosis. Now, Alternaria, we have a single typical major allergen component, and that's why immunotherapy is there. But there is not a single typical major allergen component for Aspergillus fumigatus. So differentiating these two conditions becomes a challenge. So these are the various components of Aspergillus fumigatus, and you cannot say this is major, that is minor, like that. So there are various studies. This ASPF1 is a major allergen in patients suffering from ABPA, as well as even in patients with Aspergillus fumigatus sensitized asthmatics. So approximately 80% patients of ABPA and 80% patient of Aspergillus sensitized asthma, they will show SPF1. So again, this is of no use, or this cannot be used to differentiate between ABPA and the ASA. I'll call Aspergillus sensitized asthma as ASA. But ASPF2 has been described as major allergen in ABPA patient. Approximately 87 to 100% of patients of ABPA will have ASP2 F2 positive. So the sensitivity for these in asthma is less, but the specificity is more even in ASA also. So the serospecific Ig2 ASF2 plus ASF4 plus ASF6, so they occur simultaneously. If these all are positive, then more frequently seen in ABPA patient than as compared to the ASA asthma patients, asthma patient who are sensitized to Aspergillus. So if we take into account all these three, then we can differentiate ABPA from the ASA. A very good study from our country, a study from India was able to show. So till now, before that, only the molecules which are, but in this Indian study, the cutoffs were set. A study from India was able to show that F1 more than 4.4 and F2 more than 1.3 are valuable tools to differentiate between ABPA and the ASA with a sensitivity of 100% and specificity of 81%. So I'll go through this algorithm. So if a patient IG, like for ABPA diagnosis, one of the criteria is to have positive IG, be it through skin prick test or the serospecific IG against Aspergillus fumigatus. So if the patient is asthma or cystic fibrosis, then you go for the components. Or components which are commercially available for Aspergillus are 1, 2, 3, 4, and 6. So if at least one RSF is more than the cutoff value as discussed in the Indian study, then diagnostic criteria for ABPS should proven further by the other criteria as per the ESAM guidelines. A recent recommendation ASPF21 2 plus and the total IG increase it more than 1000, but in some studies it has been shown more than 420, 419 to be more specific. Uh, Along with the ASF 1 and 2, it hints towards the diagnosis of ABPA. So coming to the limitation, I discussed about the usefulness, but what are the limitation of CRD? High cost, limited insurance coverage, not yet widely available in many of our places in our country. It may require interpretation by the experienced allergists. So CRD is a highly specialized investigation, should be restricted to allergist only, and does not completely replace skin test. So both are complementary. We cannot skip CRT because in the first step we have skin prick test, and not all relevant allergen components may be included because whatever these are available, they are from Western and the Eastern world. The country specific components are yet to be included. Interpretation challenges are more. The clinician experience is the key. So results can be complex, especially in polysensitized patient, as we discussed. Cross-reactive IG to pan-allergen can confuse diagnosis. Also, component presence doesn't always correlate with clinical symptoms. So results must be interpreted in the clinical context. So my key takeaways from my talk today is CRD enhances diagnostic precision. It distinguishes cross-reactivity from true allergy. So it will support our targeted immunotherapy then, and best used with clinical correlation. It's an evolving tool with great future potential. Thank you.
Thank you so much, sir, for the insightful session. So, we have a lot of questions in the chat box. So, I'll just come across with all the questions. One, I think Dr. Neeraj Gupta has only asked, the cutoff for labeling major allergen is over 50% or 80%?
In Pollens, it is considered to be 80%.
Okay. How to diagnose NSLTP sensitization clinically?
Basically, they will present to us with a clinical history of sensitization or having reaction, right from minor reaction to the severe reaction of anaphylaxis to various food items, right from legumes to storage seeds and fruits. So in such condition, we should think of LTP.
Okay. Keeping India's aerobiodiversity in mind, Sauropsis, Parthenium, Ricinus, or Holoptila sensitizations are found more in Western India. Can you guide on pollen AIT?
So again, depending on the primary initiator, now most of these like Parthenium, we don't have the component present over here. Prosopsis, we have that OLE one. So all these accordingly we can go by the AIT. Means depending on the geographical, clinical, the pollination season, and the component where the we have to exclude the pan allergens like prophylins. So if we have got many polysensitization to all these, if the primary from the history, if we cannot rule out, then component will definitely help here.
Okay. Most available pollens in specific IgE and CRD panels are not present in India. So how useful it is in Indian scenario?
So basically, as we mentioned, mugwort is included. We have the Bermuda grass, the Cynodon D1 is included. The trees like Prosopis, and this can be extrapolated from the OLE E1 report. So again, as we mentioned, these are few limitations where Indian allergen components to be added or yet to come.
Okay, sir. The next question is how to give AIT for ALT-A1 sensitization correlating clinically, SCIT or SLIT, for what duration?
So basically, whenever we get skin prick test alternaria positive, the next step we should go for the component, because even if strong clinical history is there, we can have a negative report from for the alternaria, the fungal molds. So because of the standardization is not there, the extraction process is poor. So in such conditions, the alt A1 helps in diagnosing the alternaria this thing, and then skit is preferred, and for a period of 3 years. But for my experience, I deal more of allergy patients. I haven't have a single patient with alternaria with immunotherapy. Dr. Sebel sir can highlight on this.
Well, thank you. I didn't forayed into the area of AIT with the fungal spores because the fungal spores have a very high protease content, very high protease content. And the Indian manufacturers, we do not have any standardized as fungal preparations. So what we end up with is that if we have really a fungal allergy and we want to treat it with, the solutions which we are getting would be have a half-life, maybe less than 1 month, it may be a few weeks. So if we are envisaging a AIT of 3 years, so which with such an unstable preparations in our hand, it is not at all a good idea to embark into that. So I have never tried AIT because of any fungal allergies. Yeah,
Okay.
so yeah. Alka, so can
So,
you move forward? Uh,
yes, sir. Yes, sir. So, no more questions now. We'll be taking if anything comes up after the panel discussion.
exactly.
So, I'll just introduce our moderator for today for the panel discussion, Dr. Soibal Motra. So he is MD, PhD, MAMS, FCCP, FIC, AAI, FRCP, FRCP, and adjunct professor and senior consultant. And his present affiliation is he is a division of allergy and immunology, Department of Respiratory Medicine in Apollo Multispecialty Hospital, Kolkata. He is visiting faculty allergy asthma program with Department of Pulmonology, Christian Medical College, Vellore. And major achievements are Index 16 publications, many publications he has, 97 international, 12 national publications, and he's principal investigator and co-investigator of extramural projects. So 9 has been completed and 1 are ongoing. So over to you, Dr. Moitra. You will be sharing the presentation, sir, or shall I continue with the presentation?
I'll share that. I'll share that.
Okay, sir. Okay.
Okay. Thank you, Alka, for having me. So at the outset, I would like to really thank the IAP allergy chapter and the Thermo Fisher Scientific for having this very important coming of the age that is a CRD webinar series. And I really thank Dr. Neeraj Gupta, who has been spearheading this current movement and of molecular allergology in India. I would rather say that. Thank you, Neeraj. Okay, so thank you, Dr. Vikram. You had an elaborate presentations and on the pollen and Aspergillus allergies. You've given an account of that, what is the landscape and what are the various allergens and epitopes. So on the basis of the premise of your talk, we'll be having in the next 1 hour some discussion among ourselves, which will highlight the nuances and the important and takeaway lessons when we are actually talking of the CRD with respect to the pollen allergies and the mold allergies. And for this, as we have very expert panelists in today's evening, it's my privilege to introduce them to all the viewers. So let me just share my screen. Yeah. So, yes. I hope my screen is visible to all.
Yes, sir.
Yeah, it's visible. Okay, thank you. So we have already had a very good introduction about Dr. Vikram Patra, who is also the one of the panelists in today's evening. So for others, we have Dr. Soundarya. Soundarya has a stupendous publication, academic contributions to 63 publication index journals, 14 chapters and e-learning modules for digital learning, DigiNow Pediatrics for undergrads and PG modules. She has got multiple accolades as like SS Manchanda Neonatology Research Award, Good Teacher Award. I really salute you, Soundarya, and Dr. S.C. Arya Gold Medal Award in the DPA program. She is the treasurer of the IAP DK branch in 2013, faculty for the allergy program in the Diploma in Pediatric Allergy and Asthma at Sir Gangaram Hospital, Delhi. She is the National Webinar Coordinator of IAP Allergy Immunology Chapter 2025, and her area of special interest and researching pediatric allergy and asthma and medical education. She is currently the pediatric allergist and consultant in Department of Pediatrics at the KMC hospitals in Mangalore. Welcome, Dr. Soundarya.
Thank you, sir.
Next, we have among us Dr. Krishna Mohan. Dr. Krishna Mohan, he is a consultant pediatrician from Kerala Government Health Services Department. He's a very erudite teacher. I've seen him talking and he mesmerizes, enthralls his students and the listeners alike. So he's a national chairperson of the allergy chapter in IIP 2024, ACVIP member 2024 to 25, the state secretary of the IIP Kerala 2024, director of the DAAI course in Kozhikode, Kerala, director of the food allergy master course, the chief editor of the Essentials of Pediatric Allergy, editor of the case-based reviews in pediatric allergy, editor of the recent updates in pediatrics in 2024, associate editor of IAP Standard Treatment Guidelines, associate editor of IAP Color Atlas, and associate editor of Textbook of Pediatric Allergy in 2019. Welcome, Dr. Krishna Mohan. So next we have among us Dr. Aratrika Das, very good friend of mine, and she's a senior consultant pulmonologist at Narayana Dale in Kolkata. She's also director of the Kolkata Chest and Allergy Center and associate professor of pulmonology at GIMS Medical College, Bajpaj. His awards accomplishments are she was a topper in MD exams in Mumbai University, has been a faculty at many national and international meets. She also has publications at peer-reviewed journals and have also contributed a chapter on allergic rhinitis in a book of allergy. A review article was published by her spirometry in an indexed journal, Pulmon. A brief experience is almost 40 years of experience in both institutional and private practice as a pulmonologist, interventional pulmonologist, and allergy management. Welcome, Dr. Atrika Das. So I would like to make a comment at the initiation, but this is a well thought of and cautious comment. Okay. So we all had from all our teachings and learnings of that, how do we see the patient? And we see the patient with make a clinical diagnosis, and depending upon them, we choose a tests. In the perspective of the allergy, we choose a tests like skin prick tests, so gold standard, or a specific IgE, and what the results are come, we then correlate the results with again the clinical signs and symptoms and make an allergy diagnosis. That is how we are being brought up in the allergy medicines. And so in this, we are quite comfortable. So we feel ourselves to be very comfortable in this modalities, in this way of diagnosing our patients and treating them. But now as we understand that we are foraying into an age of the molecular medicine. This age of molecular medicine is really new to all of us. Okay. So when foraying into an age of the molecular medicine, when we are dealing with more of the molecules, the epitopes, and the cross reactivities, is then we feel a little bit uncomfortable. Okay. So I, like all of us, exceptions are always there who are like, like means they're way ahead of me, like Dr. Neeraj Gupta. So I always had a very conservative approach towards the CRD, especially in the context when we talk about the pollen or the mold allergy in a country like India. As I just was hearing, one of our viewers had a very prudent question that how it is important in our country. Okay. As we all understand that in the landscape of the allergy, India is growing. Okay. But at the same time, we should be sensitized to what the world is saying. So if we do not get sensitized to that, we cannot improve upon that. And just take into account from the Indian context, like how our patients recall their history. We are in a tropical country. Okay. There is the pollen seasons of the trees, weeds, and grasses that overlap. With the climate change, there is changing in the pollination period and the pollination season. And at the same time, we do not have updated pollen calendars in place in our country. So we all seek to the pollen calendars, which are maybe a decade or more older. And at the same times, the anamnesis, that is the history taking, is pretty much dependent upon the patient's recall, and there's lots of biases in that. And patients may not give the proper history, and also because of the overlapping seasons and all, this may be quite faulty. So what we just come down to, it all boils down to something that is we all are confused about. Okay, maybe we all end up doing a test, getting lots of positivity, and then the patients and the physicians are equally bewildered. So in this context, what is the way forward? Way forward is, you see the CRD is giving very specific information of some of the instances. Well, if this is present, this is a true sensitizer. Yes, it's clinically significant. If this is not there, this is absent, or some other epitopes is a cross sensitizer. So we can actually tease that out and then implement the clinical context, and we can come to definitely a plausible diagnosis in the terms of the clinically relevant allergens, and which will help us to take the treatment decisions. But again, all said and done, we do not have that information for all our pollens. But it does not mean that we are not going to have them in the near future. Definitely, we're going to have them. More and more researchers in all the top Indian universities in the research institutes are going on. But we're definitely going to have this epitopes. We have many of the epitopes now we already know, and more are in the pipeline. So all this, so we would like to weave the entire discussion on some case studies, because we all love, we're clinicians, we all love to work on the case studies. These are not the real cases. These are some cases which have been provided by the Thermo Fisher to us, just to give a platform on which we can discuss the entire thing. So before we go into the actual case studies, I would like to have or discuss among ourselves, for us and also for our viewers, some of the basic tenets of the CRD. So if I would ask Dr. Krishna Mohan that, can you just tell us in brief that what information does the CRD gives with respect to when you talk about the allergens? And I know Dr. Vikram has stated in law, but let us just reiterate it. Please, can you just help us and tell us what does information the CRD gives with respect to allergens?
Thank you, sir. So as far as CRD is concerned, when you are comparing with the traditional extract-based testing, as Dr. Vikram Patra beautifully explained, the most important thing which it helps is in the identification of genuine sensitization. So we are having cross reactivity. So CRD definitely helps to distinguish between true sensitization to the cross-reactive components. So that is a very, very important thing. Second thing is regarding the risk stratification. That is, we know certain allergen components are associated with more severe reactions, and some are associated with less severe reactions. So CRD can help to predict the risk of systemic reactions or anaphylaxis. And that point also Dr. Vikram Patra has told. So especially in the food allergy, it will avoid unnecessary avoidance of foods. So usually, especially from the general practitioners, what we follow is that if we are found to have any food allergy or anything, blindly they will tell to avoid a list of foods. So the risk stratification will help to avoid such blind avoidance of foods, and we can be more specific only to those allergens which the patient is specifically allergic to, need to avoid that. And the third point is regarding the treatment, where CRD may guide us for immunotherapy. So we are in the era of precision medicine. So by pinpointing the relevant allergenic molecules or the specific protein, CRD can assist more in our allergen immunotherapy. And also it helps in monitoring of the immunotherapy also. So these are the major points by which CRD can help in our day-to-day allergy practice.
Yeah, thank you, Dr. Krishnamohan. You have so nicely stated the basic tenets of why CRD and why it is needed for our practice and why it is giving information about the allergens. Absolutely true. So if I would ask Dr. Aritrika, see, when we all talk about the allergens, we all mean that how do you define an allergen? Allergen is basically a protein which can bind to an IgE molecule. Okay, so this is very important. It is not saying something which can produce an IgE molecule and then bind to it. Any molecule bind to an IgE molecule is an allergen. So that means it might have produced it, then produced by someone else. So, and that too, we know that having all the allergens per se positive does not mean that it's causing clinical allergy. So there is always an allergenicity risk spectrum. So what is this allergenicity risk spectrum that we hear so much about in context of the pollen or the spore allergies? If Dr. Ratik, if you can just tell us something about this. Dr. Aritrika, are you there?
Please unmute.
Yeah.
Yeah.
Can you hear me now? Yeah.
Yeah, we can hear you.
Yeah. At the outset, let me congratulate Dr. Vikram Patra. I mean, we have nothing to say apart from what he has shown in his presentation. And the other thing I would like to say is, Dr. Moitro has very rightly said, all these years, the allergy therapy or the subject of allergy did not pick up because patients would come and say, they've been asked to avoid all kinds of food. Whether they would, live on water and air, that would be their question. But today, with the newer diagnostic tests, and also when we have to see the risk of allergenicity of different molecules, this part has been really covered well. Now, content and the type of protein in the molecule basically determines the allergenicity, right? Now, by molecular sensitization detection, we can actually phenotype the type of allergy the patient is having. Now, when we talk about how can we specify how much of allergenicity risk factor is there with either pollen or spores, one thing that first comes to mind is morphology. Morphology of the particular molecule is more important in case of pollen allergy than spores allergies. For example, if the molecule is, say, spindle-shaped, it travels fast in the air, and of course there is more of, it gets settled in different areas, so there is more of spread of allergenicity. Again, these pollen particles, those which are allergenic, they lack actually one particular factor in their cell wall, and that is known as um, that is known as an indexing. That is one layer of the cell wall. Now, if that is lacking in the cell wall, what happens is there is more outpouring of the proteins from that pollen. So those pollens are very allergenic. Thirdly, I would say that size of the particle, that's very important, because usually they tend to settle in the nasopharynx, but certain proteins of the pollen, when they come out of the pollen wall, and if they come in contact with any type of fluid, water basically, they give out or they form a starch-like product which can go down into the airways and then directly affect the lower airways too. However, in case of spores, which are known to cause the different hypersensitivity reaction, morphology of the spores actually, it has been seen not to correlate with the risk of allergenicity. The only one correlation, a moderate correlation, has been found in one study, where it was seen that smaller the spore particle, the more chances of having hypersensitivity reactions are there. Usually they cause different types of hypersensitivity, or a combination of hypersensitivities are found. And besides that, when we talk about the spores have different methods of survival. Now, certain spores we have found that they have been found to survive in very adverse situations. Asexual spores, for example, they are present in huge numbers, so their allergenicity is much more than the other types of spores. So these are some of the factors which actually tend to tell us how severe the allergenicity will be. What is the risk of allergenicity in different pollens and spores?
Yeah, thank you, Aratrika. You have so nicely and elaborately stated the entire thing. So whenever we are saying that there's an allergen, say it's a Pro-P3, which is NSLTP, and there is a spectrum. Spectrum means from the green, the very low risk, to a red, which is a high risk. So if a allergen as a molecule is positive, then what is the risk of that causing a severe allergies? We know that the NSLTPs like Pro-P3, they are towards the red part of the spectrum. That is, their causing of allergenicity is quite high, rather than say Pro-P1 or maybe the AMP-A1. So very important for us to acknowledge and understand that risk stratification of each allergens is quite different from the correlation of positive predictive value with the symptom. So that means NSLTPs have higher risk stratification for causing an allergic disease, severe allergic disease, than maybe major storage proteins are higher than obviously the defensins and the defense proteins. Thank you so much. So quickly, I would just like, so when we are all discussing, we say that we are doing the testing in this way and that. So very commonly we say about the singleplex testing, the multiplex testing, especially in the context of the CRD now with the nanotechnology which has come in, the platforms like the Isaac and the Alex too. So Sandhya, can you just quickly tell us that what is the singleplex and the multiplex? What do we actually mean by that? Because we were using this quite often in the context of the CRD.
So thank you, sir. Thank you, Tama Fisher. Thank you, Neeraj, sir, for this opportunity. So singleplex and multiplex platform of testing is that the singleplex testing tests only the Ig antibodies against a single allergen component. So this is useful in very narrow spectrum single testing, primarily if there's a very clear-cut clinical history and there's no doubt. That time, just to confirm, we can use the singleplex testing. Here we need a larger volume of blood, and this is a very sensitive method. Very low levels of Ig antibodies also can be detected with the singleplex testing. Primarily useful once you start immunotherapy and you're tailoring it. Yes, very useful singleplex. The multiplex platform is what is now we are evolving towards. This measures the Ig antibodies against multiple allergenic components, and it helps in detailed profiling of sensitized patients. Now, this is very useful when patients have complex clinical histories, they have multiple allergies, and it's very difficult to pinpoint one particular component, and we are confused with cross reactivity. That time multiplex platform is useful. The advantage is that it's on a microchip, so a small volume of blood is sufficient. Plus, in pediatrics, that does help. And though this is slightly less sensitive as compared to the singleplex testing, it helps to distinguish between this cross-reactive and the specific true allergy can be identified by all the algorithms, like how Dr. Vikram had very nicely presented. We can identify exactly which is true sensitization, which is cross sensitization, and which is co-sensitization. So that is the main patho behind the singleplex and the multiplex platform of testing, sir.
Yeah, thank you, Sandhya. Yes, very beautiful, extremely good. Because we now understand that when we are actually bringing up the mean the entire utility or the entire potential of a CRD, we now know that a CRD entire potential, to know it, we need to see all those the cross-reacting networks which is working in the particular patient. And for that, all the third generation platforms that now we have been seeing, which has come in our hand. There's the Alex2 or the Isaac. Okay, they are used for nanotechnology, small amount of blood, and with that they can do the entire all the specific IgEs to the epitopes. That means we get the entire thing. That is the multiplex system, and this really it's one of the biggest which has been an advancement in the allergy testing, which has been seen. I would take a cue from the same thing, what you have said, Dr. Sandhya. So means Dr. Vikram, Dr. Sandhya said a very, very important point over here. It's a co-sensitization, cross-sensitization, true sensitization. What do you actually mean by that? If you can just again tell us that.
Yeah. So very important to know. Now, when CRD was not there, so we were dependent on the skin prick test only, and that is quite good because that is still the gold standard one. But if I restrict to myself to the pollens only, so when we go for pollens, so skin prick test may show positive result to two different pollens per se. And when you reconsider the history, you may come to know that both those pollens, they are the same season, the same pollinating season is there. Then you are confused. And many a times, the polyimmunotherapy, immunotherapy with multiple allergens were given. Now to narrow it down, it is always better which one is the primary sensitizer. So for if I take into account again the Artemisia and the Ambrosia. So if I consider if both are in the same season, so if I take Artemisia, I go for component result diagnosis after skin prick test positivity. Then if component of Artemisia ARTV1 comes positive, and whereas the AMBA1, which is the major allergen or the signature allergen of the ambrosia, is negative, then I'll say that this is a primarily Artemisia sensitization, and that ambrosia which has come on the skin prick test, that is just because of the cross sensitization of the minor allergens like profilins or the other minor allergens. So here I will restrict myself for giving immunotherapy to only one. So this is what is called as cross sensitization. Then, but if on the component result diagnosis, if the signature molecule of more than two allergens come positive, like AMBA1 also comes positive, Artemisia V1 also comes positive, then I'll say ki both are the that is called as co-sensitization. That is a true sensitization for both those conditions. I gave the example of the peanut. Even our Himalayan belt people, they eat peanuts. So in them also, if birch V1 is positive, BT V1 is positive, and along with that, the major ARH2, RH2 is also positive, then I'll say this is co-sensitization. Birch is also positive, even the peanut is also positive. But if only the RH8 comes positive with the BET-V1, then the reactions will be mild, I know. A processed peanut the patient can eat, so avoidance to peanut should not be need not be given. No need to give the adrenaline injection also. So this is because of the cross reaction. So this is how cross reaction, cross sensitization, and co-sensitization can be formed.
Yeah, beautiful. Thank you. I think there is no room for any confusion anymore, because now we understand that that antigen or the allergen which has got into the body tweaked the immune system to produce an IgE, and then itself binds with the IgE, is the initiator or the primary sensitizer. So all those who are doing all those antigens which is doing this, they are all the primary sensitizers. So if we have two or more primary sensitizers, it's a co-sensitization. But if because of the molecular mimicry, because we see lots of molecular similarity in the lipocalins, in the polcalcins, in the NSLTPs, the other antibodies is what they do is that maybe that is as we have seen that in the NSLTPs, or maybe the polcalcins, they themselves do not go and tweak the immune system to produce IgE, but they can bind with the IgE which has been produced against the primary sensitizer. That is a cross reactive. Beautiful. So let's now come to the cases. Okay. So this is case number 1. Nina, who is a 17-year-old 17-year-old girl, and Peter, who is a 19-year-old boy. Okay. Both with a history of birch pollen allergy. We have seen birch pollen allergy is so common in Europe, which is the healthcare provider after experiencing oral symptoms when eating apples. So Nina gets intense oral itching, while Peter gets oral swelling and throat discomfort. Both are experiencing rhinitis during spring and early summer. It has become worse for Nina, but remains stable for Peter. Nina and Peter's healthcare provider conducts a full clinical and physical examination of both and decide to test using an apple components. Okay. So now then let's see that what happens. This is now they have done a skin prick test, like the skin prick test. So they have done with a birch, and it shows in the Nina's that is it is to be quite high. That is 4 plus, and in Peter's also 3 plus. And they also had this rhinoconjunctivitis during spring and the early summer. So this actually gives it's really it means I would really like to ask one thing, and I would like to ask Dr. Krishna Mohan, what do you think that was the concordance of the skin prick tests and the CRD with respect to the pollen allergies? What is the level of concordance we have?
So even in this case, we can see that SPT and CRD are not always concordant, because the skin prick test we are using the whole allergen extract, whereas in CRD we are looking for the components. So some of the patients will be having a positive SPT due to the cross-reactive components. Just now, Dr. Vikram told about the cross-reactive components like profilins and procalcins. So that may be positive due to the cross-reactive components present in the extract. But CRD can clarify if the sensitization is due to a genuine marker allergen or just due to a cross-reactive protein. So even in this particular case, we can see that CRD will help in distinguishing between the major allergen, that is the BET-V1 and the cross-reactive. So SPT and CRD are not always concordant, because and that is this non-concordance which makes CRD more specific.
Yeah, that is very true, because that is why we are doing the CRD, because we are doing the whole allergen. We are testing with the skin prick test or specific IG, but the CRD we go into the components. Yeah, that is the most important thing. So then these are the results of the Nina and the Peters immunocap. And so what we find is that they have this MALD1 allergen component, which is positive in the Nina, and this is positive and this is 8.1. Well, not very significant in the Peters as result, but still positive. But MALDI 3, it is quite highly positive in the Peters result. So means though we see here that the treating physicians, they have embarked on the immunocap, and they want to see, because they're all, because we all can see that it's an oral allergy syndrome because of the BETV1 component, and they have got directly into the immunocap. Maybe a little bit they have done SPT. So what we call there's a top down approach and the bottoms up approach. And maybe the world is moving towards a bottom up. We are still in the top down, or maybe the prudent way to go in a U shape. So, Arati, can you just tell us what is this top down approach? What is this bottom up approach? What is a U shaped approach when we are making an allergy diagnosis, especially in the context of the CRD?
Well, in the top-down approach, first we do the top-down approach, go on to the bottom-up approach, and that forms the U curve. Now, in top-down approach, what we do is when the patient comes, we take a good history, we look at the symptoms and signs of the patient, and also we ask the patient if the patient had any previous history of exposure to the allergen, knowingly or unknowingly. And then we identify by skin, the usual test, skin prick test, or maybe specific IgE. We identify whether what allergen, about which allergen we are thinking about, which are causing the reactions. In the bottom-up approach, what we do is we identify each and all the molecules and their potential clinical relevance. So in each antigen has several molecules, and we have to identify those molecules, that is again by the CRD technology, and the relevance of those molecules to formation of the symptoms. Now, this is known as, when we do both the things together, that is known as a U-shaped approach, when both these are combined together. And what is the importance of this U-shaped approach is, by this approach, we can actually tailor the treatment given to the patient. This U-shaped approach is very useful when polysensitization is shown, and when we are not very clear about the type of allergen we are trying to address, or the patient gives us some history about atypical symptoms. In these cases, this U-shaped approach towards diagnosis of allergy becomes helpful.
Yeah, thank you, Aratrika. Thank you. So I would just like to ask Soundarya a pertinent question. If you just look into this result, you see that to the birch whole allergen, Nina's results are positive, Peter's are also positive, and to the apple whole allergen, both are positive again. So, and from the history that we have seen, that is that both of them are having allergic rhinoconjunctivitis, most likely a pollenosis, the pollens because of the birch pollen, and also they had symptoms when they ate apple. So it was, we know it's most likely an oral allergen syndrome, or the pollen allergy, pollen food syndrome, whatever we call it. And then because of this cross-reactive, there's the allergens, both of them had the symptoms. And well, there was this component testing was done mainly to tease out which are the components which are there, and then to get some extra information out of that. But tell me, Soundarya, that means in a country like India, an LMIC country, okay, where we have to be very judicious and very carefully use these test results. What are the, means, just tell me whether this was needed in this situation, number one, and can you see some situation where further molecular testing is actually necessary when we talk in context of the pollen allergy? Dr. Soundarya.
Yes, sir. Thank you, sir. So here molecular testing is we look into molecular testing only when we have confusing results. Like in this patient, in these two brothers sister, we have confusing results. Both have been positive for immunocap as well as for skin test for birch. Both the siblings have been positive, and like this, when they are both positive, and we know that birch has got a very high cross reactivity with apple, that is when a detailed immunocap is useful to identify one and two, three, four different profiles to explain to the patients how to go further. For giving an example, now this MAL-D1 protein is heat labile protein, whereas the MAL-D2, 3, 4 are non-heat labile, they are stable proteins. So how much of this heat lability can be exploited in which of these siblings, all this detail well explained only if we know that this patient is MAL-D1 positive or not. Otherwise, there'll be complete food avoidance, because we know, if we know only in general that birch core has cross reactivity with apple, we will not be able to tell them exactly how can they avoid the food and how much to avoid, and whether they can alter the food because of the heat lability and still tolerate the food. So that is one situation where this further molecular testing is needed.
Yeah.
Yes, sir.
No, please go on.
And where we have pollen food allergy syndromes. In pollen food allergy syndromes, it is very useful, especially when grass pollens, like with cynodon, like Cyn D12, want to all react with tomato, they react with the other melons. All these things is very useful because some are pan allergens, some are major allergens. So the minute one comes positive, automatically tomato, melons, all will get avoided if we just look at the basic panel. By knowing if the major one is positive, the other cross reactivity can be identified, and then the correct food allergy syndromes can be correctly tailored and explained to them. Immunotherapy also, yes. By giving, like for this patient, if we give immunotherapy against the birch, it may really help them tolerate the apple also at some point of time. Perhaps all these things is why molecular is the way forward.
Yeah, absolutely. I cannot but agree with you more. Yeah, you said it very nicely. So we have the differential diagnosis of Nina as a birch pollen related apple allergy, and the management plan to avoid raw apples, continue the antihistamines, and maybe this thing was important for her. And for the Peter also, Peter had IgE antibodies is to MALD3. So this is very important to understand, because MALD3 is basically, is an LTP. Okay, so there's a higher risk of developing severe and systemic reactions, because we know LTPs, I was just talking about, it is quite high up in the allergenicity risk spectrum. So we have to be more, or because more cautious about with him. So strictly avoid the apples. Always, this patient has to be given an adrenaline auto injector, antihistamines for the birch pollen and all. And so that is how it should be. That is very important. So let's come to the next case number 2. So 23-year-old man, Adam, and 28-year-old Ben. They have both suffered from recurrent severe rhinoconjunctivitis for the last 6 years in the spring, which we call spring catarrh. Both the patients are considered for the specific immunotherapy by the healthcare provider. But before making a decision, identification of the primary IgE sensitization at the molecular level was important. And Adam and Ben's healthcare provider conducts a full clinical history, physical examination, decides to test using grass and birch pollen components. So again, what we see is that both in skin freak testing with Adams and the Benz, both the birch and the Timothy grass pollen extraits come out to be positive. So means we can think that whether this is a co-sensitization, or what is it? Should they be given? Should their AIT extract contains both, but then the immunocap with again specific IG done for the whole allergens, and this also has come out to be positive for both of them. So they were diagnosed with a grass and birch allergy, and just recommended the use intranasal steroids, antihistamines, and things like that. Now their immunocap was done, okay, because the healthcare provider wants to be more sure of what is it. So see, this is a bed V1. It is 10.1 in Adams and phlegm patterns 1, that is for Timothy grass, is in Benz. So it has made the things very clear that the Adams immunotherapy extracts were very different from that of the Benz. So actually, when we talk about this tree polar birch and all, so Dr. Vikram, can you just reiterate once more, like what are the major tree pollen allergen families, and just with example of signature allergen in one or two of them, Dr. Vikram?
Yeah. So basically, again the spectrum. So we have NSLTP on the higher side. So we have beta expansins, which are present in the grass pollens. The PHLP1 is the beta expansin. Then we have these PR10, which are specifically for the tree. They are the signature protein family or the allergen family. Then for weeds, we have pectate lysase, methylpectinase, those are there. So BET-V1 is the PR10. PHLP1 here in this case is the beta expansin. And then even in tree as well as in grass, we have these polcalcins, we have profilins, we have LTPs, which are common to all these pollens.
Yeah, means yeah. Yeah, Vikram.
Yeah. Hello.
Yeah, okay. Yeah, please go ahead. Yeah, tell me. I think I
Yeah.
got.
Then we have this Ole E1 like family that is exclusive to olive and which shares with the Babulda acacia over here and the prosopis. So there are different. Then one more group which is not being commercially tested frequently, that is the Oleaceae. Oleaceae family. There, the patient will come to us with having history of significant IG mediated reaction. But when we are doing with the SPT or the serum specific IG, they may come negative because they are not represented in the crude preparation. So Oleaceae, when we do for Oleaceae, we can prove that the patient has got reaction or the sensitization is there.
Okay. Thank you, Dr. Vikram. Yeah, means the same thing. When we talk about that is the major families. Well, in any plant kingdom, the major families talk about is the BED-V1, then the profilins, the cupins, and the polamins, and also the polcalcins are coming. These are major families we talk about, and then we see the of what is there. So in this, hello, am I audible?
Yes, sir.
Yeah. Yes,
okay.
sir.
Thank you. So we see the Adams-specific IG to the individual birch pollen component BED-V1 because the birch pollen SIT is appropriate, or specific IG to cross-reactive polcalcins BED-V4 and the PHLP7 actually positive to the grass extract results. So obviously the Adams healthcare provider gives him a birch pollen SIT, and so Adams pollen symptoms improved with that, and he is doing fine. So in the absence of the IG against and BED-V1, because pollen sensitization is not originating from the birch pollen, it's not an initiator allergen. So Benz is mainly the PHLP1. The grass pollen is SIT is appropriate, and so he was treated accordingly. Okay, thank you. So let's move ahead to case 3. I think we go through the case 3, have some questions, and then maybe we have only 15 minutes left with us. So and if time permits, we can have another case. So it's Patricia, a 16-year-old girl with a history of seasonal rhinoconjunctivitis during early spring, goes to see her healthcare provider because her symptoms have been getting worse the last 2 or 3 years. She also has been experiencing oral itching when eating peaches and wants advice regarding her potential beach allergy. A healthcare provider conducts a full clinical history and physical examinations and decides to test using peach and the birch allergen components. So this is the birch is again the positive. Patricia's test results were negative to ash, grass, and mugwort. So like we know that this is the weed and all this is the grass and this pollens. So just before we move forward with this, so Dr. Krishnamohan, can you just highlight which are the marker allergens in the context of when we talk about the weed allergens in the form, like when you talk about that is the mugwort, the artemisia. So which are the marker allergens or the signature allergens among the weeds, Dr. Krishnamohan?
The signature allergens, as Dr. Vikram has highlighted, we know the ragweed or the ambrosia, AMP A1 is considered as a major marker allergen for ragweed, and the mugwort, it is Artemisia. Art V1 is the marker allergen, and he also had highlighted some other names also. One Paritrea was there. PAR J2 is the marker allergen, and some other things which are not relevant in the Indian scenario, like the English plantain and all. I don't remember it now. But AMP A1 and ART V1, the ragweed and mugwort are the most the signature allergens.
Yeah. Thank you. I think these are the main one or two, but basically what you have said is that is the right. Dr. Sandhya, if you, I can just ask you, like just in the continuation of when we're discussing about the pollens, if you know the grass pollens are the most prevalent pollens, and to cause the clinical symptom, they're also most common. So this is the grass is the most common. So can you just tell us, like, which are the major allergens of the grass pollen? And we have this interesting phenomenon of the thunderstorm asthma. And we talk about thunderstorm asthma, we talk about grass pollen so much. And so like, what is the role of the CRD in this context, Dr. Sandhya? And with
Yes.
go ahead with this case.
Yes. So the major grass pollens which widely in forest grasses and we have grass. Since the forest grasses are not mainly involved in allergy as such, their allergenic profile has not been detailed. Even the urban grasses in India, there is not too much detailing on the epitopes. But the primary grasses which have been so far found in India, the most common is the cynodon, the Bermuda grass, which the main allergen is the beta expansin CYND1. The other common grass in India is the Timothy grass, which is Plerium pratense, where again the major allergen is PHLP1, which is also beta expansin. Other ones which are important in that is the PHLP2, 5, and 6, and now even the PHPL4 is found to be an important marker recently. Another grass in India, especially in the northern parts of India, is the rye grass. The rye grass is the Lolium prenen, now LOLP1. This is also a beta expansin, and the LOLP2, 3, and 5 are the major components which are allergenic here. Abroad and outside, there's another orchard grass, which is Dactylus glomerulata. There are many studies on this Dactylus with DACG 1, 3, and 1, 2, and 3, which have been found to be allergenic and cross-react. And all of these grasses cross-react with melons, tomatoes, peanut also cross-react with the parthenium, other weeds, mugwort, and as well as trees. Now, coming to the other question you asked me about this grass pollen and thunderstorm asthma. Now, the ETSA, which is the epidemic thunderstorm asthma, this is a very common phenomenon in places where there is large grasslands with thunderstorms, most commonly detailed in Australia and Melbourne. Here, during the event of a thunderstorm, there are multiple supercharged particles all over the air, and pollen grains, which are normally 30, 20, 25, 30 micrometer in diameter, because of the ambient humidity and the supercharged particles, they develop swelling because of the osmosis, and the charge causes them to fragment. This fragmentation releases a lot of the intracytoplasmic starch granules into the air, And these starch granules become less than 5 micrometer. And now the pollens, which were primarily into conjunctivitis and rhinitis and didn't go further, now become completely respirable particles reaching the lower bronchus. That is by precipitating this epidemic thunderstorm asthmas. So these thunderstorm asthmas are very unpredictable, and usually they are known to occur in those who are uncontrolled asthmas, very significantly grass allergic and fungal allergic patients. So the importance of CRD in this is that since the whole unpredictability of when such a grass or a fungal allergic person can be involved in a thunderstorm is there. So if we profile these patients and find out whether they have major allergen sensitization to say cynodon or ryegrass or timothy grass, which are the three main grasses for whose pollens get easily fragmented, we can plan immunotherapy, and that is said to go a long way in helping these patients, because this can be very severe, the amount of asthma which can get precipitated because of that. So that is the importance of CRD in such thunderstorm asthma, especially with the grass pollen, sir.
Yeah, thank you, thank you. So means in this also, like, we come to a birch pollen allergy and birch pollen related food allergy in patient, in this patient. So means we see that repeatedly we have been using this in a diagnosis, and then we come to a conclusion of a diagnosis and decided whether the patients would benefit from the AIT or not. So Dr. Vikram, can you just again just in very short just say that how will you place CRD in your treatment decision and algorithm when you take a decision for an AIT in your patient?
So basically, as we discussed in our last thing also, that if we are getting co-sensitization or we are getting cross-sensitization. So if we are getting cross-sensitization, we'll go for the immunotherapy of the allergen where the molecule or the signature molecule is present. So we'll not go for the cross-reactive allergen. So by just mixing, if we don't do CRD in such situation, we'll land up in giving multiple allergens in one vial, and that further diluting the concentration and leading to ineffectiveness of the immunotherapy. So focused, the targeted immunotherapy can be done by knowing the signature molecule.
Yeah, exactly. Thank you so much. That means when we have dual sensitizations on a skin test or specific IG to whole allergens, and we need to find out which one is the real culprit or the triggering allergen, we need to resort to the CRD. Thank you very much. So I would just almost to the end. So I would just like to ask you one very important, because we need to cover up this mold allergy. So just tell me, Dr. Krishna Mohan, that as Dr. Vikram has already stated, can you just tell me that how can CRD in a diagnosis of the ABPA during the recent ISHAM ABPA guideline that published in ERGL last year? We do not see any role of the CRD. They mainly concentrated on the total IG more than equal to 500 and specific IG more than 0.35. So, but with the new study which has come up, how do you place CRD the diagnosis of the ABPA?
So it may help us in distinguishing this ABPA from the simple Aspergillus tuberculosis sensitization, so which can usually be challenging due to the cross reactivity. So how will CRD help? So if you remember that picture shown by Dr. Vikram, if we can get an idea regarding the specific AF components, and it has been said that the ASPF1 and ASPF2, if they are elevated, it is a clue. There is a more chance for it being a ABPA. So I'm not sure whether the recent ISHAM criteria is considering the CRD as a diagnostic criteria or not. But because
not yet.
not because the latest Indian criteria that recently released by IAP, that from the Joseph Sir and team, they are not mentioning CRD. Only the specific IG is mentioned. But patients with a high levels of as F1 and as F2, they may be having a more chance for being ABPA. So is it so, sir?
Yeah,
Saibal, sir?
yeah, absolutely. The recent ISHAM, we do not have the incorporation of the CRD, but as means SPF recombinant SPF1, then a recombinant SPF2, they're positive and the cutoff values are there. They are highly suggestive of an ABPA. Yeah, means why this recombinant thing has come up? Because why can't we use the native allergens? If I just can you just, Dr. Sandhya, put some light on this? Why do we talk about recombinant? Why in all these things? Why not a native? Why? Because what is this CCD, which is actually masking many of the diagnoses? Just tell us a bit about the CCDs.
So the thing with native allergens is that native allergens are whole allergens and they have multiple components. And among those components is a component called the cross-reactive carbohydrate determinant, which is the CCD. This cross-reactive primary glycosyl. They are of numerous types. They can be carbohydrate based primarily, or which are cross-linked glucose based moieties. There are also different other type of carbohydrate determinants which come under these. The importance of this is that these CCDs, they confound our skin prick test and specific IG test because they stimulate the formation of IG antibodies against these components as well. So if a patient is shows a positivity in the skin prick test and a high specific IgE, it could not always be to the major allergen. It could also be to the carbohydrate cross-reactive determinants also. But the important thing is that these CCDs are not clinically relevant, and they only confound the clinical investigations both in vitro and in vivo. Because of that, there was a very nice study which I saw where they said that they had done a study on grass, and they found that the patients who were positive with grass major allergen, actually they were CCD negative, and a large proportion were CCD positive, showed sensitization in the specific IgE and skin prick, but were actually major allergen negative, both with Bermuda grass and Timothy grass. Similar studies have been done even with mugwort as well as with fungi, showing that these carbohydrate determinants are there, and they tend to confound the clinical picture by imagining that the clinical symptoms are because of that. However, through CRD, these CCDs can be identified. Once identified, we can know that if they are negative to the major allergen, that is not responsible for the clinical symptoms. That is why that CCD and their IgE response is very important and to be identified in CRD.
Okay, thank you. So, like we have discussed so much about the CRD in this context. So, I would like to ask one last question to Aratrika. I know Aratrika has been using CRD a lot. She is one of she has the most experience, largest experience with the CRD from Calcutta, I would rather say. So, Aratrika means what do you say? What should be the approach towards your use of CRD in the clinical parlance today in our context?
Yeah, I would say everything has already been said in this talk. So what I'm going to do is just to summarize the points. So number one, most important thing is when we talk about allergy, we need to pinpoint the allergy. When we talk about sensitization, we need to pinpoint it. So the most important part or the most important advantage of CRD technology is we know exactly which component of the molecule is responsible for the clinical parameters that we see, which are clinically significant. For example, suppose initially we all do a skin prick test, which is still not, which is still considered to be one of the gold standards. Now, suppose a person says that she doesn't know what she's sensitive to, but at different times she has been having these allergic features. So we find in the skin prick test, suppose there is a positive sensitization to wheat. When we do a CRD testing and we find there are 3 antigens of the wheat molecule and one particular antigen, that is, I think, TRI 19 something. I don't remember the exact number, but that is positive, that is responsible for the clinical manifestations of the disease. If the other 2 are positive, they are the minor antigens, and then they have no relation with the clinical features. Now, the other thing is, it has also been seen, suppose someone's IgE against, say, DERP1 and DERP23 are positive at a very young age. They are the ones who actually go on to develop asthma later on in life. So to find out these features which correlate with clinical manifestations, this is one very important test. Secondly, as we have already discussed, finding out the main antigen and the cross-reacting antigens, differentiating between the 2 groups, that's very important. Thirdly, CRD helps us in recognizing which patients, as we have seen in the cases, which patients would require or be benefited by immunotherapy, which patients will not be benefited by immunotherapy. So these are some of the very important criteria based on which we can actually go ahead with CRD after the skin prick test is done. So proper interpretation is very important for any CRD testing, because without interpretation, it doesn't carry any value, right? So these are some of the criteria by which we can choose CRD in our clinics after doing the skin prick test or a specific IgE test.
Okay, thank you, Ratrika. You have very nicely and comprehensively you have put out that thing. So I think we can just quickly have the questions there in the chat box. First, many of our ABPA patients are getting SPT sensitization to Curvularia, Alternaria, Rhizopus along with Aspergillus. How to interpret this? Dr. Krishnamohan, would you like to say something on this?
So I think as a algorithm was shown by Dr. Vikram, which may help you to uh, clarify that, because he has shown an algorithm. But regarding the other allergens, I don't know.
No, absolutely.
The Aspergillus we can do, but the other allergens I don't know what.
Yeah, see, that is absolutely means all that is same for all of us. See, we are only seeing the sensitizations, and we know with the whole allergen, the sensitizations, there is loss of cross-reactivity among the fungal allergens, so they can show positive to it. So, but that does not have any clinical significance. Either we say as ABPA, and if the ABPA, the essential criteria is not fulfilled, that is the total Ig is raised, but specific Ig is not raised, and other criteria are fulfilled, that is the eosinophils are raised, that is CT findings are there, and clinically in the context of asthma or maybe cystic fibrosis, we say it's an ABPM. Thank you very much. So most of the practitioners nowadays is a very practical question, and Pankhuri has asked, uses CRD as a tool for allergy diagnosis, leaving behind history and skin prick tests and other basic tests. That doesn't know cross sensitivity. Yours clear-cut take on for that, Dr. Soundarya.
So yes, the knowledge of CRD is very new, and till now it has remained only in the realm of the allergologist and immunologist only, because what she has written is very correct. We should use CRD. Yes, there is a cost issue, which I also feel everything. blankly avoiding foods when your treatment is not giving you desired result, then it is always better, rather than doing it as a series, we should opt for CRD so that we can help our patients better. It is not just do everything blanket upfront and get confused. The knowledge of CRD and how to interpret it is equally important, and titrated to a patient scenario should be done. Hopefully, after this seminar, they will.
Yeah, thank you so much. Dr. Neeraj has sent a message for all of us. It's very important that he says a singleplex is better than multiplex. Okay, you know why he said that? It is because you know how the multiplex is done. We all say that it is the third generation platform, and with a small amount of blood, we can see allergenicities to the many of the allergens. But remember one thing very clearly: whatever test we do in our labs, it has to be actually compared with a standard curve. Okay, so there's a standardization and a standard curve with which it is being done. When we are using this nanotechnology in the multiplex, we usually resort to the standard curve, which is given by the total IgE or the whole allergen IgE. It is not the standard curve, is not developed to the specific IgE epitope. So that's why we call it a semi-quantitative test. It is not a quantitative test. Specific IgE by immunocap is a quantitative test. If we are using a singleplex system, it is a quantitative test, but multiplex is a semi-quantitative test. Whenever a test is a semi-quantitative, we have too many important things that comes down, that for a semi-quantitative test, you cannot use a Fagenson nomogram to come to a positive predictive value or a negative predictive value. In that, you again have to resort back to your history, the clinical context, and also to the other test and maybe the patient's perspective. So this is one of the very important point that Dr. Neeraj has presented it. And I think this is very much important for all of us to acknowledge. See, whenever we're using one platform, when we talk about the benefits of that, we should also know the limitations of the platform. Because we do not know the limitations of the platform, it will be like we are all out for that. No, we should know where are our limits, our limitations, and everything should be analyzed within that limitations in a particular patient's perspective. Thank you, Dr. Neeraj. And with that, we end today's discussion and on the CRD with respect to the pollens and the moles. I really thank Dr. Vikram Patra for his elaborate, extensive talk. I thank Dr. Krishna Mohan. I thank Dr. Saundarya. I thank Dr. Aratrika Das. I thank Alka and the entire team of the Thermo Fisher. In the end, I really thank Neeraj Gupta for actually making the entire thing happen. Thank you so much. And I would like all of you to have a one-liner or for your viewers and the entire thing. So let's start with Dr. Krishna Mohan.
Yes, sir. First and foremost, thank you, Dr. Saibal, sir, for that excellent moderation, and thank you, Dr. Neeraj Gupta, for that arranging all these things. So the last point that we mentioned, we should not misuse this thing. It should be only for those which are clearly indicated. It should not be a tool for misuse. But the last question that Dr. Neeraj asked, the single plus versus multiplex, the problem is that in many of our cities we are having the multiplex, but the singleplex is not available. If you want to test house dust mite alone, it is not available, but this Alex and this thing is available. So that has to change somehow.
Yeah, Dr. Ratika.
The most important part of CRD is interpretation. And without a proper history, without a proper examination, and correlation with the diagnosis, also a skin prick test, we cannot interpret it properly. So then there are more chances of it being misused.
Yeah, Dr. Saundarya.
Sir, I think all ahead of me have summarized more than enough. I'd just like to say that when we do a thorough history, like what Madam said, thorough history examination, and come to the CRD panels and their reports, I think we should follow algorithmic approaches, like Dr. Vikram has said, so as that to exactly identify what we are dealing with and go further, rather than just looking at it at single value. So a good algorithmic protocol approach is very important.
Is Dr. Vikram?
I would like to say over here, basically, we all, as an allergy in all our talks, we always say not to send panels. So I'm afraid that that CRD multiplex may become one more panel. And here is the advantage of singleplex beside the limitations of multiplex. Now we know what we want to look for. If we are looking for dust mites, we should only send the dust mites. Why we should send other things? So the for focus therapy, we need to go for the singleplex only, and that's very specialized. After detailed history, as mentioned by everyone, we should not randomly do for all our patients.
Dr. Neeraj, are you there?
The big
Sir,
boss has to say something.
Yes, sir, I'm there.
Please sum up the entire thing.
So I think it is actually very difficult for me to sum up, but what I understand is that whenever you are ordering any test, I usually say this to everyone. It is not related to allergy, it is related to even a common sense. We should first understand that why we are ordering this test. We should first think that, okay, if this test comes positive, what we are going to do? If it comes negative, what we are going to do? So a question should come first before ordering a test. If we are having a valid question in our hand, okay, whether this particular immunotherapy could be two allergen, one allergen, why this is not acting. And then thereafter we should decide, okay, now this particular test is going to help us. Then we need to order. On the other hand, I think one of the person has correctly pointed out a point that nowadays what is happening that because of the availability of this good panel, big panel of components, the tests are ordered, and then the patient comes to us with, you can say, like a whole battery of probably 100, 200, 300 components, and now we are in the middle that what we have to do. There are so many positives, so many negatives. Even component result diagnostic is also not, you can say, like sacrosanct. This is also having a good amount of false positivity. So we need to really understand that false positivity can also be there. Even false negativity can also be there because it is only testing certain components. There are other components which are missed, which might be tested in the whole allergen. So that is why nothing is sacrosanct, nothing is 100%. We need to really first ask the question that what question we need to answer, and thereafter we need to decide.
Okay, thank you. I would just like to add one final comment from my end is that when we talk of this CRD, you know why we talk about these panels and entire thing, everything done. See, always understand one thing that we all need to acknowledge is the human being is at the center of the everything of all exercise. Everything around him or her is an allergen, so which is called an allergome. So it is in the allergome network and its interaction with the human genome and manifesting it in the form of the transcriptome or metabolome or whatever it is, ultimately leading to a disease. So it is basically the entire thing which is interacting and forming a disease. So what this CRD tries to give is not a tubular vision of this entire interactome in the form of the allergome. I'm specifically using these terms because these are used nowadays to give rise to specific disease, but it is not a tubular vision, but an entire vision in the entirety, the cross sensitizations, the true sensitizations, the co-sensitizations, and the disease. So today we are all going towards the age of the big data, AI, and omics. So let us try to understand, this is basically gives us a very big amount of knowledge and very big amount of information. And utilize that in your patient's perspective for the treatment is just we are learning, taking the baby steps now. So please, all of you who is in this, do not take CRD as just a test which is done and we just order the panel and do it so that it will just actually defeat the purpose. So use in the right context, right patient with the molecular allergology user's guide on your desk. And then you see what is the interactome, and then you decide upon what is happening in that patient. It's going to give us marvelous results which no other test can and give, but has to be used very judiciously with much prudence and knowledge for it. Thank you very much. So I'd like to just ask Dr. Alka to just finish that thing so that we can all say good night to all. Dr. Alka.
Thank you so much, sir. And it was really a wonderful session by Dr. Vikram Patra, followed by a wonderful panel discussion that we had. And really, the last statement of Dr. Artika, that, well, as you mentioned, that pinpointing the sensitization, pinpointing the allergy is most important, and interpretation of all these allergies. And I hope so. This seminar is really helping all the attendees to get all those interpretations correctly and treat the patients well. So thank you so much, everyone. Thank you all the panelists, our speaker, Dr. Neeraj Gupta. Thank you so much. And just another information, we have our last session, last episode next Friday, same time. So do join. I'll be sharing the link again by Monday or Tuesday. So please do join back for the last session of the series. Thank you so much, everyone. Good night from Thermo Fisher. Thank you.
Good
Thank
night.
you.
Thank
And good
you.
night.
Good night.
Bye.
Thank you. Thank you, Saibal.
Bye.
Thank you.
Thank you. Good night.